It's time for another Morning Pointe Foundation Caregiver Café, part of the work of the Morning Pointe Foundation, providing nursing scholarships and caregiver support programs across the Southeast. Thank you, donors, for supporting our 4 annual Seniors Got Talent shows and our 2 annual golf events. And now, bi-monthly virtual caregiver cafes featuring senior living experts. Dr. Matthew Kodsi is a board-certified neurologist with over 25 years in the medical field. He is now the Vice President of Medical Affairs for CHI Memorial. As a volunteer for the Alzheimer's Association for over 12 years, Dr. Kodsi has an uncanny ability to help others understand the complexity of Alzheimer's disease. Joining us tonight is Amy French with the Chattanooga-based Alzheimer's Association. She had the opportunity to sit down recently with Dr. Kodsi and have him answer some of the most frequently asked questions when it comes to this disease. Please welcome Amy French with the Alzheimer's Association to the Morning Pointe Foundation Caregiver Cafe as she shares her conversation with Dr. Kodsi. Amy French is the Senior Manager of Programs and Education for the Alzheimer's Association Tennessee chapter. Amy's role focuses on care and support for those affected by Alzheimer's and other dementias, the patient, the caregiver, and the community. And be sure to stay to the very end, as Amy French will take all of your chat questions, pulling from her professional and personal experience as a caregiver. Welcome.
Hi, everyone. I'm Amy French. It's a pleasure to be here with you this evening. I've had the opportunity over the 12, 13 years that I've known Dr. Kodsi to ask and hear others ask countless questions. And there's never a time that I sit down with him or I'm in the same room with him that I don't learn something new or I'm not reminded of something that I had forgotten and needed to be reminded about. I'm so grateful to Dr. Kodsi for sitting down with me and allowing me to share this conversation with you. And I'm particularly thankful to Morning Pointe as well for their long partnership over the years in bringing community education and support to you. So without further ado, I'm going to turn things over and allow you guys to listen in on the conversation I recently had with Dr. Kodsi. Put your questions in the chat, and as soon as our conversation concludes, I'll jump on and answer all the questions I can. Thank you so much for joining us. Well, good evening, everyone, and thank you so much for joining us. We are going to jump right into our questions, and just as a reminder, you're having the opportunity to meet Dr. Matthew Kodsi. Dr. Kodsi has practiced, as you know from his bio, for many years in the field of neurology, and he currently serves as Chief Medical Officer for CHI Memorial here in the Chattanooga area. Dr. Kodsi, it's a pleasure to have you today, and I'm so excited that we get to practice some of the resilience and some of the think outside the box that caregivers practice every day. So thank you so much for being with us.
My pleasure, Amy. Thank you.
Well, you and I, having worked together for over 13 years through your volunteering with the Alzheimer's Association, have learned, I know, right? We started when we were 3. I like to say that. It's been a minute, but we've had such a great opportunity to share knowledge and experiences with numerous caregivers over the years. And one of the things that we learned early on when you and I first started working together was how important it is to give caregivers the opportunity to ask the questions that are most important to them, the things that they want to know. The more formal presentations that we often do, that Morning Pointe has offered, that the Alzheimer's Association offers on a regular basis, those things are very, very important. But what we want to do this evening is really focus on just those practical questions, that boots on the ground information that folks need to move forward as caregivers and to get the support and the knowledge that they need. So I think I'm just going to start with what you and I have discovered to be our #1 most frequently asked question. What is the difference between Alzheimer's and dementia?
Sure. That is the one we get most commonly. So when people talk about dementia, I think it's important to understand that dementia is not a disease. Dementia just describes the symptoms that the person has. So I tell people, when you say dementia, it's like saying car. If I say car to you, you have an image in your mind of something that has four wheels, a motor, and it gets you places. If I say a patient has dementia, that tells us as doctors that that patient has problems with their memory. They have problems with other areas of thinking, be that doing math to make change or finding their way in the neighborhood, that together make it difficult for them to live independently. They need some help. So when I say car, you might ask me, well, what type of car do you have? Is it a Toyota? Is it a Honda? Is it a Chevy? Same thing, if I say someone has dementia, then we would ask ourselves, what is the disease that causes that dementia or causes those symptoms? And the most common disease that causes dementia is Alzheimer's disease. Somewhere in the 70 to 80% of people with dementia have Alzheimer's disease. There are a number of other diseases that can cause dementia, Parkinson's disease among them, but they are less common.
So when you talk about dementia, what would be considered the signs of dementia?
Sure. So what we're really looking for, if you're looking for someone who has memory and other thinking problems, is we're looking for a change. And I know that sounds simple, but in a sense, it's really the essence of it. So for example, I had one patient with Alzheimer's disease who used to be an accountant, and they started having some trouble making change at the store. So that was a real change for them in a skill that was hardwired, just burned in, because that's what they did all their lives. So if someone has a strength, they're good at math, they're good at finding their directions, they're always good at making the plans for the family, and you see they're developing problems with that, it may not mean for sure they have dementia, but that can be concerning, that it may be early signs that that's what's developing.
So how do I know if myself or my loved one has Alzheimer's, or if they're just getting older, they're just aging?
Fair enough. There are some changes in memory, for example, as we get older, but they're not significant changes. Maybe there's a slowness, so it takes an extra minute or few seconds to remember something. But things like, for example, if you park your car in a lot and it takes you a few seconds extra to remember exactly where you put it, that's typically not dementia. If you park your car in the lot and you spend an hour looking for your car because you have no concept of where you parked it, that's very concerning. And I think at that point, if you see something that is a notable change, then it's important to get that checked out.
You say to have it checked out. What would be the next steps if I detect those kind of changes in myself, or most likely if I detect them in a loved one? What would be the next steps?
So I think it's important to discuss it with your primary care physician. And many primary care physicians are very comfortable doing the tests that are needed and the evaluation to figure out what's going on. Some physicians prefer to go ahead and refer you to a specialist like a neurologist or psychiatrist to evaluate for dementia, but either way, you could have it worked up in one of those places. Now, I think I know the next question would be what would they do? So really the most important thing to remember when you're taking a loved one to be evaluated for memory problems is do not send them alone. Because the person who goes in and has the memory problem is not, one, likely to admit they have a memory problem, and two, is not going to be able to give the best story of what has changed. So it's very important that you go with them. You can tell them what's different. How is this person having difficulties that they didn't used to have? Now that can be awkward. A lot of people will say, well, I feel really awkward going in with my father and in front of him, or my mother in front of her, telling the doctor all of these things that I've noticed. So I think one thing you can do is you can actually go ahead and write something up. Get that to the physician when you arrive for the appointment. Get that to the physician in advance of the appointment so they can look it over. That can be helpful. Now, I would make a strong recommendation that you not do that in single space 2 or 3 pages, like a long summary, because unfortunately the physicians, they just may not have time to really give that the attention it deserves. So what I strongly recommend is to use bullet point Just a few key things. This is what I've noticed. Point 1, 2, 3. These are the big changes. And that may be 1, 2, 3, 4, 5. But at least if you do it that way, then the physician is going to be able to have time to look at that and give you the time you need for the appointment.
I think that's excellent advice. As a care consultant for the Alzheimer's Association, one of the things that happens frequently is, a son or a daughter may contact me and he or she will say, well, Dad's just been having all kinds of challenges. He's been leaving the stove on. He can't remember who his grandchildren are sometimes. And I finally got him to the doctor, and the doctor asked him how he was doing. My dad said he was fine. So the doctor didn't do anything. And I always say, unfortunately, that's not unusual, but doctors can only treat what they know is happening.
Right.
I learned that from you. That's actually one of your quotes.
I had a patient just like that. I saw him for years without family. It was a very quick visit. He had a very simple problem. We didn't delve into anything. And one day his daughter called me with very serious memory concerns. And when I started to ask him the right questions, it became obvious. So to your point.
Yeah.
And so then once you're there with them and you can give the information, we can tell 90% of the time just from hearing the story what's probably going on. But we also do an examination. There's a short memory and thinking test called the mini mental status examination. It's a 30-point test, and we can say what scores we would expect based on someone's age and their education. And we can see from that, are we concerned there's a sign of a problem? And then we look at a few things. We look at blood tests to look for things that can cause memory problems that are actually treatable. There are certain hormone levels, like the thyroid hormone, that if it's low, it can slow down people's thinking. There are vitamins such as B12, if they're low, that can cause memory problems that can improve if you give B12. So we do those blood tests. We also do a picture of the brain. Now, there are a lot of different pictures of the brain that you can get. There's a CT scan, there's an MRI scan, there's the PET scan that's out there that can be done. My preference is to do an MRI, and I'll tell you why, because the CT is sort of a rough picture. I tell people it's like looking at a black and white photo from 5 feet away. An MRI is much more detailed. I say it's sort of like looking at a high resolution color photo close up. You can really see what's going on. And the key things that I look to see is there shrinkage of the brain. That is something we often see in a lot of diseases that cause dementia, particularly in Alzheimer's disease. And I can actually look at the particular parts of the brain that shrink in Alzheimer's and see if I see those changes. I can also get a really good look to see if there are any signs of old stroke changes, scarring in the brain from poor blood flow that can cause memory problems. So those are the few of the things I look for.
Yeah, and I think it's so important that we as laypersons who are not physicians, who are not medical practitioners, that we know and understand that, the changes that are occurring in our loved ones' behaviors, in our loved ones' ability to remember and retain and use information, they're a result of not just a normal part of aging, but of a disease process that happens in the brain. And I think knowing that it is a disease process makes it easier as a caregiver to be more sympathetic, maybe more empathic, more understanding, and not to take it quite so personally and feel so much frustration that you as a caregiver can't change the situation. We don't have the ability to wish away a medical condition. And that is what Alzheimer's and other forms of dementia are medical conditions.
Right. I think one of the hardest things for a caregiver is that the person doesn't look sick. They look the same on the outside. So why shouldn't they be the same on the inside? So it's hard to adjust to this person who is so different from a loved one you may have been with for 20, 30, 40, 50 years. So it's a challenge.
It is. And I think too that, one of the things that just getting that thorough annual wellness exam, that does include some of the testing for cognitive decline. Those things are paid for by Medicare. And often, one of the things that I suggest caregivers often do is, if their loved one is reluctant to go to the doctor, is reluctant to discuss the things that are happening with cognitive decline, with challenges with memory and behaviors and so forth, is to remind them, this is something that your Medicare pays for, and we want to get our money's worth out of our Medicare because we're paying that premium every month. So sometimes that's a good way to get folks to agree to address medical issues, not just dementia, but other comorbid conditions too. And we know that cognitive health, our brain health, is related to our body health. So having all of that covered is so very important.
Right.
Well, let's talk a little bit more about the symptoms that do occur with Alzheimer's and other forms of dementia. We know that they're related very much to a disease process that happens in the brain that creates problems with retaining information and with using information, making sense of the world around us. But we do know that it's not just about memory loss. There are other behaviors that can manifest, challenging behaviors, things like hallucinations, false beliefs, things along those lines that often are the catalyst for people reaching out for help for their loved ones who have dementia, because those behaviors can be very challenging. And I'd like for you to talk a little bit about some of those challenging behaviors that do occur. And this is a long two-part question, and some of the interventions that are most therapeutic in that regard.
Sure. So you already mentioned too, so hallucinations is when people think they see something that isn't there, or they misunderstand something that is. And that's really a part of, as Amy said, the disease process, in that their brain is having trouble understanding what they're seeing. So it makes them think they're seeing something else. And I think one really important part of that is, in a sense, when you have a loved one who has dementia, to keep in mind, is it is best not to argue or disagree, because they truly believe that what they're seeing is real. So, for example, I guess the one I always think of is if they're looking out the window and they say, look at all those kids out there, they're coming at the house, and they get scared. You don't say, oh, no, those aren't kids. What are you looking at? Because then they'll get upset, and then you'll get frustrated, and they'll get frustrated, and it just escalates from there. So I think the most important thing you can do is acknowledge what they see. You can, let's say, look out the window, and you look, and maybe you see that there are trees in the yard and it's dark, and you could say, you know what? I see why you think why those look like kids. I can see that. You know what? I think they're trees. I'm going to go check. Let me go downstairs. So acknowledge what they're seeing, maybe come up with a possible alternative that makes them less anxious, and then go outside. And then when you come back in, you might say, oh yeah, it looks like that one's got a shirt on and that one, but they're trees. Or if they say they see something that isn't frightening them and it's not harmful, there's really no reason to argue at all. If they say, oh, look, you see that cat run across the room? Sure, why not? It's not going to hurt to agree. If they say, look, the sky is green today, it's not hurting anyone, then fine. There's no reason to disagree. It's only if it's something that frightens them or makes them anxious or makes them upset, you need to try to help calm them. The other thing you mentioned was delusions. So that's a belief in something that's not real. So some very common beliefs are infidelity. So the spouse is having an affair, or someone's stealing their money, or someone's taking their clothes and substituting them with clothes that aren't theirs because they get confused. Again, you don't want to argue, although the infidelity one is tough not to disagree with. I think you have to find a creative way of acknowledging their concern and then having a response. So for example, oh yes, I know, your husband, I saw him, he was at the store with this very young woman, this really nice saleswoman who was helping him. I think he was trying to get you a surprise gift. Something that doesn't disagree with them, but shows that you see what they were thinking. And that's challenging sometimes, very, very challenging. And then sometimes people get very impulsive. They get just angry out of nowhere, and they can't control their emotions or their anger. So there are a number of different medicines that we can use for these. I really tell people you pick the medicine based on the symptom, based on what you're treating. So for example, for the things like the delusions, the false beliefs, or the hallucinations, those are symptoms very similar to what we see in diseases like schizophrenia. So there are drugs that are used to treat those diseases, and we use them in much smaller doses in people with dementia, and can have good success with that. And for the agitation, the temper, there are medicines we can use to sort of even keel. So there are a number of medicines that can be used.
I love the way you touched on, the fact that there are medications that can help with those things. And I know that oftentimes physicians have a great challenge finding the right combination, and that's not an unusual thing. We have to remember that those medications were developed to treat a different disease process. The symptoms are similar, but the disease process is different. And
Right.
we're also dealing with a brain, as we learned earlier, that is damaged by a disease process. So it doesn't work like your brain or my brain would. And that makes it very challenging. So I encourage caregivers to be patient and very communicative with their doctors if a medication that is helping with those kind of more challenging symptoms is being tried. So I really encourage, like I said, strong communication with the physician on that. And don't give up, don't give up.
Right. Agree.
Yeah. And I also love the way you touched on how important it is that, we as caregivers, and I say we because I went that road with both my mother and my mother-in-law as a caregiver. In one case, I was a long distance caregiver. In one case, I was a very hands-on caregiver. So I got to see it from both situations. And I learned that it is absolutely true that we as caregivers have to learn a skill set that we never thought we would have to learn. And we have to accept that it's okay to do that. Things like, as we've learned to call it around the Alzheimer's Association, therapeutic fabrication. In other words, it's okay to lie to your loved one. It's a hard one because we as human beings, our culture, lying is not okay. It's not something that we do. And especially in the case of lying to your spouse or lying to your caregiver, it feels like a lie when you say to them, oh yeah, I see those kids out in the yard. They look like they're having a really good time when there are no children there. Or, saying, well, yeah, shoot, yeah, tomorrow's Easter. Let's go pick out an Easter outfit and color some eggs. When we go along with them, we have to understand that we have to restructure our thinking in that. While it may feel like a lie on the surface, what we're actually doing is entering their world. They can't come back to our world. Their brain works different now. We've learned that it looks different. It functions different than our brain. So their reality is different. And when we take that leap, or even that simple step to go into their world, if it's causing no harm, if it's doing no damage, if it's causing no anxiety or fear, then going to their world is the kindest thing we can do. And it's a way that we can engage positively. And that's what we really want. We want connection with our loved ones. They want connection with us. And when we're able to enter their world and be a part of that, rather than trying to make them come back to our world when they're not able to, then that can make all the difference. And it can certainly make for a much better day in and day out.
I mean, I think to the point, and when you use the term therapeutic fabrication, the therapeutic part is the important part. The goal is to do what is best for your loved one who has this disease. And if they are calmed by believing something or seeing something that doesn't bother them, then the best thing is to agree with them, to go along, to try to find, not to try to convince them. And that's another thing. If they say today is Thursday instead of Monday, the best thing for them is to just say sure, not to convince them or remind them that it's Monday, because keep in mind, when you do that, they might just be aware enough to get frustrated with the fact that now they realize that they've made a mistake. Yeah. And that will actually make them feel worse. So you want to try, obviously we know, to make them feel as best they can.
Yeah. I do want to circle back around because we've talked about some of the medications that might be used for some of the more challenging behaviors. You know, across the board, there are medications that are often given when a person is diagnosed with Alzheimer's and other forms of dementia. And I'd like for you to spend just a few moments talking about those common medications and kind of what the expectations need to be in regard to
Sure,
what those medications can do.
sure. So there are two different groups of medicines that are used to treat dementia, particularly Alzheimer's disease. One, there's only one medicine, so I'll start with that one. It's called Namenda or Memantine. That's the generic, and it's been available generic for a while now. And that's a drug that it's a 10 milligram pill. And I don't always go into detail, but I've learned it's probably important to understand that I've seen people start on a low dose, which we always do, but the goal is to build up to the full dose that's 10 milligrams twice a day within a month. And I've seen people be on 5 milligrams once a day for 2 months or 5 milligrams twice a day for 2 or 3 months. The standard goal, unless someone has other medical issues, and your doctor would be aware, is to aim for 10 milligrams twice a day within a month. Now, what does that medicine do? It acts to decrease the action of a chemical in the brain that is important for the memory circuits to work, but in Alzheimer's is believed to be a little overactive to a point where it creates noise in the system. So this drug tries to bring it down to a level where it can function more normally. The other group of drugs, there are actually three medications, although pretty much there's two that are used most often. There's Aricept, or the generic is donepezil. There's Exelon, the generic is rivastigmine, don't try to spell that. And then there's Reminil, or the generic for that is galantamine. Now, all of these are available as pills. I will tell you the Aricept is also available as an orally dissolvable pill, so if someone has trouble swallowing pills. The Exelon is also available as a skin patch, same thing if they have trouble taking pills. The Reminil, I believe, I don't want to misspeak, I think it is available as a liquid. And I forgot to mention that the Memantine is also available as a liquid. So there are a lot of different ways you can take these medications. But traditionally, one of those medicines, either Aricept or Exelon or Reminil, is given in combination with the Namenda, the Memantine. Now, you don't start them both at the same time because that can be a bad idea. You never know which one caused a problem. But traditionally, you start one, and then once you're on the full dose, you add the other. Now, what are the side effects? So with the Memantine, it's usually tolerated pretty well. Some people get a little bit of balance trouble. I don't see that often. Some people get a little constipation, which actually turns out to sort of be a good thing because the side effect of the other drugs, the Aricept, the Exelon, and the Reminil, is that they can cause stomach upset and sometimes diarrhea. So what I often would do is to start the Memantine first, get that to a full dose, and then add the other drug. And that has been shown somewhat to lower the person's chance of getting diarrhea or stomach upset. So those drugs, I think, and Amy mentioned, to set, what's your expectation? Are these drugs going to make their memory better? Is it going to get them back to normal? Is it going to stop the disease? Unfortunately, in a sense, none of those are the standard expectation. We would like to see the memory get better, and it may. I've actually seen patients improve quite a bit sometimes on these medicines. But the real hope for me when I give these medicines is to either keep the disease where it is or to slow it down, really. Now, none of these have been shown to stop Alzheimer's disease, but people who take the medicines have kept their memory and their thinking sort of level for longer than people who didn't take the medicines. So I say that also because I've seen people years ago who would say, well, we're going to try it. We're going to give you Aricept for a month, and if your memory doesn't get better, we're going to stop it. Well, a month is nothing. I mean, this disease is 10, 15, maybe more years for some people. So 1 month gives you no idea whether the medicine is going to change anything. So in my mind, once you start these medicines, it is a commitment, unless your family member has side effects that make it that they can't tolerate it, or they're getting worse so fast that it's very clear the medicine isn't doing anything.
Well, that makes a lot of sense, to go into it knowing kind of what the medications do and what to expect from those medications. And it's a process, as I said, with dealing with the symptoms of the disease, and in this case, with those particular medications, sort of what's going on in the disease process. And that is not a different approach than is taken with managing any chronic progressive illness. And that's what Alzheimer's and dementia is, chronic and progressive. So it's not surprising that, the medical management of it does require some expertise. And we're very fortunate that that is something that is available in many cases. So kind of talking a little bit more about medications, we hear on television, if you watch Jeopardy every evening, which most of us will probably do after this, then we know that, there's all kinds of products on the market that are said to improve memory, help prevent Alzheimer's disease, help reverse Alzheimer's disease. Can you comment on some of those over-the-counter medications?
Sure. I mean, those medicines have not been shown scientifically to make a difference. So, I mean, some people say, well, can I take it just in case? I mean, my perspective is as long as you check with your physician and there's nothing in there that's going to harm you, and harm includes emptying your wallet, then it's not unreasonable. Someone is making a good deal of money on these medicines, and it frustrates me to see that. But if it makes someone feel better to take a supplement that's not that expensive and it's not hurting them, I'm not opposed. But I do say that none of those over-the-counter supplements have been really shown to help the disease.
But there are things that we can do to reduce our risk, right?
Sure, absolutely. I mean, I tell people all the things that we have been told to do to keep ourselves healthy for years can also be helpful in keeping your brain healthy. So exercise, eating right, staying mentally active, reading, doing puzzles, doing things that keep your brain active, staying social. All of those things can be helpful. Getting the sleep you need, make sure you get your rest. All those keep your brain healthy.
And I think, all of the things that you talked about are the things that caregivers, especially that first degree caregiver, the person who's there day in and day out, they have tremendous challenges providing that kind of self-care, making sure that they themselves get good nutrition, that they themselves get exercise, that they themselves get social and cognitive stimulation that they enjoy. So much of their life is wrapped up in the day-to-day of the hour by hour, the minute by minute, making sure that their loved one is safe and cared for. And one of the things that I want to emphasize to caregivers, and that I learned again firsthand, even though in my mind I should have known better, how important it is to make your own self-care as much a priority as the care of your loved one. It is a challenge. It is hard to do. And I remember during the time that I was caring for my mother as a primary caregiver, I remember thinking that trying to get my exercise in, get my sleep in, get my nutrition needs met, and maintain my relationship with my other family members and my job and everything else, I remember feeling very overwhelmed. And I remember thinking, well, eating badly is just another thing, or eating well is just another thing that I'm failing at. I'm just not doing a good job. So when we talk about those things that caregivers can do and need to do to take care of themselves, I encourage people to really break it down. Don't sweat it. The number one best thing a caregiver can do for him or herself is probably to forgive him or herself for not being perfect, because none of us are. And it is a huge challenge for caregivers. So give yourself a break if you're out there worrying that you're not doing a good job as a caregiver, because you are. The reason it feels hard is because it's hard. So speaking of caring for our loved ones, and again, I draw on my own personal experience, there came a time when my sisters and I, as co-caregivers, had to begin to look at meeting my mom's needs, perhaps in another setting. we simply, even the three of us together, could not provide the level of care that she needed to be sure that she was getting maximum care. So how do you know? How do you know when it's time to consider maybe a secure memory care community for your loved one?
So that's something that comes up frequently, of course, in the clinic. And it's something that's agonizing for family members because for so many reasons, they want to keep their loved one at home as long as possible. There's a sense of duty. And of course, you want to take care of your, it may be a spouse. It's often, as in your case, a parent. You feel that they did that for you, they raised you, and you want to be there for them. But I think it comes back to the theme of you want to do what's best for them. And there comes a time when, as you said, Amy, the care that you can provide is not enough. It's not what will keep them safe. It's not what will keep them, what's the word I'm looking for, as comfortable as possible in their situation. And I also think you asked me, when do you know it's time? My response, and I know you've heard it over and over again, but it's, when you're starting to ask yourself, is it time? That usually means it's time. Because when you start to think about it, then it means you're realizing that the care you're providing it's not enough. And as hard as that is to come to terms with as a caregiver, it is essential both for you, because to your point, if you start to do more than you're capable of, then you are going to be the one who ends up sick and, God forbid, in the hospital. And if you try to care for them in ways that aren't meeting their needs, then that's not good for your loved one either.
Yeah.
So when you start to think about it, have the conversation with your physician.
Yeah, I think that is wonderful advice. And just knowing that, when you're caring for your loved one, you have to take all of those things into consideration, as well as your ability to provide that level of care that's needed. And it's not a failure when that time comes. It's the nature of a progressive chronic terminal illness.
You are never,
yeah,
right,
we would never attempt to solely and single-handedly manage the care of our loved one who had ALS or Parkinson's or other kind of chronic progressive diseases. But yet there is a stigma, and there's a hesitancy that we have. As you said, Dr. Kodsi, they often don't look sick. He can still walk around. He can still go to the mailbox. He still wants to drive the car, even though we don't let him anymore. So all of those things make it very difficult. But coming to that conclusion is hard. And when you have a physician that can support you in that, it's very, very important.
I agree.
So we're not too far from wrapping up, and I'm going to ask the question that everybody wants to know. Do you have any news about the latest in Alzheimer's research and treatments?
There's so much going on. I keep hoping. I mean, we know that one of the drugs that was approved recently, but now is certainly more challenging to get, is the aducanumab, or the Aduhelm. The reason once it got approved and then it became somewhat less available is that the studies weren't as strong as we would like to show that there was clear benefit from that medication. So the feeling in the scientific and the medical community was we need to look a little more. And so that drug really has been limited to be used in direct trial use for now in a very limited fashion. But we're hopeful. And there are a number of other things that continue to be researched to help the disease.
Yeah, and I think what you said is so important for us to keep in mind. We are hopeful. We have reason to hope. We have a plan. The research community has a very specific plan. Every year, the Alzheimer's Association and other organizations advocate for more and more funding to be sent the way of Alzheimer's care and research. And every year we get it, because Alzheimer's is an expensive disease. It not only impacts our loved ones and ourselves personally, but it impacts our Medicare budget. And that's what motivates oftentimes that increase in funding, which is so very important. And I know that not only do we have reason to hope that medications are being developed, medical interventions are being developed, so very important. We know that every time there's I hate to use the word failed research project, so much is learned that catapults researchers leaps and bounds further than they knew before that research study started. So when you hear about a failed trial, don't get discouraged by that. Know that with every failure, as we see it, tremendous gains have been made in the battle.
Right. It's what did Edison say? I didn't fail 1,000 times. I learned 1,000 ways not to build a light bulb.
Yeah, that's perfect. That's a great analogy. So we're pretty close to wrapping up. So I just want to hit you with one more.
Sure.
Do you have any tips on how to talk to your loved ones about possible memory care issues and next steps in treatment or care?
So you're talking about, I'm not sure I fully understood your question, Amy. You're talking about how to talk to caregivers about pursuing next level of care for their loved one with dementia?
Well, no, I'm talking more about how, circling back to your loved one, and he or she is reluctant to address the problems that he or she is having. What suggestions do you have for maybe helping them feel more comfortable seeking out
Medical help.
Yeah.
So you're talking about early in the, early to mid in the
yes.
disease. Sure. So, I think, and to your point, I always like your suggestion of, we want to get the most out of our Medicare money. Let's make sure we check everything. At the same time, I think sometimes you have to resort, much like you said, the fabrication, to finding a different reason to get them to the doctor. So they might not want to go for the memory problem that they don't think they have, but they might be willing to go because, their arm's been hurting for a little while, or they stubbed their toe, or they have occasional headaches or something that they are motivated to talk to a physician about. And you use that as an excuse to get them in. And then on the side, as I said before, you might write a little thing up and hand it to the physician and say, hey, by the way, can you check on this too? It's getting them what they need, but trying to find a way to do that in a way that doesn't make them anxious or uncomfortable.
Yeah, and I think just that, being their advocate and picking up the baton when they're not able to make that kind of decision, make that kind of move in their own best interest, to pick that up. I know that when I was, keep circling back to when I was a caregiver for my mom and for my mother-in-law, my mother knew, had enough cognition to often say, I just hate that you have to take care of me. I know it's such a problem. And I would tell her over and over again, because she'd forget, she'd ask me that question or made that comment over and over again. I would say, Mom, you took care of me, and it's my honor to take care of you. And it is, being a caregiver is a labor of love. It is an honor. And it has been an honor to talk with you, Dr. Kodsi, and to just sort of have this kind of nice casual discussion in which we, I hope and I think, have imparted some good insight, some good information, and hopefully some real genuine support to people who are out there struggling with this disease and trying to figure it out. Hearing from an expert like yourself, hopefully hearing from someone who has a caregiver perspective, such as myself, has been helpful. And that's why we're here. It is our honor and our privilege to help each and every one who's joined with us today. And Dr. Kodsi, I want to thank you. You have been, as always, wonderful, and you are much appreciated by myself and by everyone in the community.
It is always my pleasure, Amy, and my honor to do these presentations with you as well. Thank you.
Thank you. Wow, so many good questions asked and answered in such eloquent and helpful ways. I'm going to jump immediately into the questions that have been posed in the chat during our discussion with Dr. Kodsi. And don't forget, you can add questions as we go along. So I'm just going to start with the first one, and it's kind of a hard one, I'm not going to lie. My dad is constantly making derogatory remarks to my mom and telling her he's going to leave her. Is there a way to handle that? That's a very difficult one. It's so hard not to take things like that personally, because it is personal. When your husband is saying unkind things, making threats to leave, those kind of things are so hard to hear. But I think what we have to understand and remember is that all behaviors, maybe especially the most difficult ones, are forms of communication. And it's very likely that this person is feeling a lot of stress, a lot of feelings of inadequacy, a lot of confusion. So it's very hard not to engage and to banter back when a person says unkind things to you. But redirecting is probably the best way to handle a situation like that. When the harsh words come, the "you're so stupid" comes, the harmful words come, rather than responding emotionally, which is very difficult not to do, maybe redirecting to say, well, I know you're getting frustrated, but you know what? Let's just go have some ice cream. Or, you know what? Andy Griffith comes on in 5 minutes. So let's go into the living room and get ready to watch Andy Griffith. I just love how Gomer Pyle, yada, 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 and go on and redirect rather than trying to convince him that he doesn't need to leave, or that, that he's not really mad at you. Redirecting is the best way to manage that. And, we're all human. Even redirecting is difficult. So sometimes walking away is the absolute best thing to do, to say, well, I need to check on the roast in the oven, whether there's one there or not, to walk away and to redirect. Our next question is, my mother's doctor has prescribed medication for dementia, Sept, and I'm needing help to determine my next steps. I'm very concerned for my mother's ability to live alone. And I'm also concerned with her behaviors as it's becoming increasingly more worrisome. Well, Dr. Kodsi did address some of the medication concerns or medication recommendations. So while the Sept is a normal part of the regimen, asking the doctor for the additional use of Namenda and the combination of drugs that are commonly prescribed will be the best route to go in regard to addressing the medication issue. And in regard to determining what next steps may be and the concerns for safety, I believe firmly that if you're questioning whether or not mom is safe to live alone, then it is time to make some changes to assess what's going on. There are some home modifications that can be made. Perhaps it might be helpful to set up some cameras so that you can remotely watch what's going on. That's not spying. That's not being disrespectful. It's doing the best you can to assure her safety. Another possible option to consider, depending on what the financial situation is whether or not it might be time to consider a community that she can live with other people in, like an assisted living community or a memory care community. And I hope that everyone does take into consideration that when a person has dementia, it is not always necessary, depending on the level of functioning and the level of the stages they're at in the disease process, they may not need to go immediately into memory care. In my mother's situation, while we knew that she had dementia for many years and lived alone safely for many years, there came a time when it was no longer safe for her to live at home. So the next step was for her to live in a retirement community. While there wasn't 24-hour care and assistance, there was always someone there, and there was staff and neighbors and so forth to help keep watch on her and help her maneuver through the challenges that she faced because of her decline cognitively. The next step was an assisted living facility. And finally, before she passed away, she did live in a memory care unit for about 1.5 years. So can and should be hopefully a more progressive transition as the stages of the disease come about. Let's see, our next question is, could you discuss techniques or recommendations to address paranoia and or OCD symptoms that can come with dementia? Again, those challenging behaviors, they're so difficult to experience and to be a part of and to watch your loved one go through, but they are oftentimes a pretty common symptomology of the disease. Some of the recommendations to address the paranoia, then paranoia, of course, is a belief that someone is harming you or doing things that are harmful towards you, taking your money, hiding your things, that kind of thing. Those kind of things, again, it's very hard not to take personal. So redirecting, if your mother is constantly losing her glasses or thinking someone's stolen her glasses, have 3 or 4 pair of glasses. Techniques to help manage the OCD type symptoms, repetitive behaviors. Repetitive behaviors are very, very common for a person who has Alzheimer's. Asking the same question over and over again, washing the same plate constantly, dusting the furniture repeatedly. If that OCD behavior is not hurting anything, let them dust every day. Let them dust 5 times a day. It's not going to matter. It's going to make them feel more productive and more comfortable. And that OCD behavior is often a way to manage anxiety. So again, redirecting is a wonderful way to help manage those kind of symptoms. Redirecting, with an activity that your loved one is familiar with. For instance, if your mom was one who loved to keep a neat and tidy house, maybe just keeping a hamper full of towels or clothes to be folded. Those can be folded again and again and again. It doesn't matter. It's not about the folding of the clothes. It's giving mom the opportunity and a task that helps her feel useful, that's familiar to her, and that helps alleviate some of that sense that she has that she needs to be doing something. Because most moms, I know my mom never sat still. She was always busy. She never sat down and watched television. She was always doing something. So finding ways to engage them in activities that are meaningful to them. And remember, that's the key, that those activities be meaningful to them. Our next question is, you spoke about being a caregiver for your mother. How did you know when you needed more care for her? The thing that we looked at that was probably most challenging and most difficult was that my mother wanted so desperately to hold on to her independence. She did not want to leave her home and go to the retirement community. When she got to the retirement community, she did not want to leave the retirement community and go to the assisted living facility. When she was in the assisted living community, she was hesitant and did not want to leave her friends in the assisted living community to go to the memory care facility. Those stages, each and every one, were difficult. So how did we know? Well, for one thing, we were so fortunate. I have 2 sisters and we were a 3-part caregiver routine. So we were able to discuss things and we each saw things from a different lens. And we were able to sit down and objectively discuss those things. We had an excellent physician who was very involved in my mother's care. And we were able to sit down with her, and countless texts went back and forth as we went through the processes of the different transitions she went through. And I was very fortunate. I had a very idealistic system in place to manage my mom's care. And I was very fortunate in that. And I know that not everybody has that system. I talked about how valuable it was to discuss things with my sisters because we were all on the same page. But it is not unusual that all family members are not on the same page. It's not unusual that the son who doesn't live with mom doesn't see and doesn't want to acknowledge what is going on. And it complicates things more when mom acts pretty normal when son is there. When she talks to him on the phone, she doesn't talk the crazy talk and do those unusual things. So he doesn't see it. And that's very difficult. One of the things that I've done countless times that I'm available to do on a regular basis is a care consultation, to sit down with families and go through what some of the challenges they're facing are in making decisions. So that is something that's available, a care consultation with the Alzheimer's Association. Another thing that can be done is to bring in outside help if that is an option financially. Again, it's difficult to do that. It's very challenging sometimes to get your loved one to accept that need, but bringing in that additional person, hopefully proactively before it becomes kind of a crisis situation, is a great way to handle that, to help ease into the stages of increased care that are going to be needed. Another question is, can you share details on ongoing caregiving support groups? And do you find them to be helpful? I'm so glad that question was asked. We do have a number of ongoing caregiver support groups in the community. To find those support groups, you can go to our website at alz.org/community resource finder. And I will try to put that in the chat so that you can have that access to that information. If you can't remember going to the website, that's okay. You can always call our toll-free 24/7 helpline at 1-800-272-3900. And you can also reach out to me at afrench@alz.org to get a list of our support groups that meet in person. They vary, of course, from community to community. We also have a number of virtual support groups, and sometimes that's a good place to start. One of the things that we learned during the pandemic was how wonderful it is to have the option of virtual support groups. Virtual support groups allow people who wouldn't otherwise have the opportunity to participate, and we're very grateful for that opportunity. We have a question here that is, let's see. So it says, a knowledgeable SLP specializing in dementia care has wonderful and practical tips to help caregivers on their Instagram account. Oh, this is good information. The Instagram account is at BeLikeCare, BeLightCare, or www.belikecare.com. And I recognize this person's name. I'm going to address her question now. I saw an advertisement for a program to help in changing negative behaviors in Alzheimer's patients. Is there anything out there that is valid in that regard? And I think probably what this caregiver is referring to is some of the things that you'll see when you Google challenging dementia behaviors, things like that. Honestly, probably the best way to manage those challenging behaviors is to simply follow the basic guidelines that are available on the Alzheimer's Association website. I don't think it's probably necessary or any more helpful to pay for a product that would help do that. I really think caregiver support groups and talking with other caregivers is probably the most valuable way to really learn how to manage those challenging behaviors. And do they work? Yes, it is helpful for caregivers to learn things like how to not engage when their loved one becomes upset, how to walk away when it's necessary to walk away, finding ways to help redirect your loved one so that he or she doesn't become excessively agitated. And it looks like we have time for one more question. And this is from Julie Cooper. She says, I see this presentation is being recorded. I would love for my family members to see this presentation. How can I obtain this recording? What a great way to end our day today. You can go to the Morning Pointe Foundation site, and all of the presentations are available on demand. And I encourage you to do that. I encourage you to go back and watch those that you haven't watched before, to share this one with your loved ones, with friends and family. You know, the more we know, the better we deal with what is going on in our life. Knowledge is power. And knowledge is a wonderful way to share with each other and to be on the same page as we all walk this journey together. We are so very appreciative to have you join us this evening. I want to thank again Dr. Matthew Kodsi for his expertise and his time, Morning Pointe Foundation and Morning Pointe for hosting this event. And I look very much forward to seeing you at our next presentation. Good evening.
Be sure to join us on November 10th at 6:30 p.m. Eastern Standard Time for our next virtual Morning Pointe Foundation Caregiver Café. The topic, an in-depth lecture on Alzheimer's, dementia, and caregiving with Dr. David Hutchings, Ph.D. and a geriatric neuropathologist and dementia specialist. This webinar will offer CEUs for LPNs, RNs, and MSWs through the UTC Center for Professional Education upon completion of the webinar and a required survey. Until next time, thank you for joining us for the bi-monthly Morning Pointe Foundation Caregiver Café virtual educational series. To learn more about the work of the foundation or watch any of our previous Caregiver Cafés, visit us at morningpointefoundation.com.